Hi. Um, Wrong camera. Hang on. There we are. That's me, and that's Magid. So we're both here and waiting to start. Hopefully you should be able to hear us okay. You were hearing the video and the music before. A particular welcome to Ricardo and everybody there in Porto Alegre. I hope there's more than just Ricardo. I'm not sure if we should just make a start and get on with it, or maybe we should just chatter here for a while to get used to it. Bob's joining us from Midwest Ohio. We've got Sita Maramba and Danny from somewhere in Plymouth. So we've got a few locals and South America, North America. I guess that's 3 continents anyway, so that's not too bad. I think maybe we'll make a start because according to my watch, we're 5 minutes after the start time. So what we're trying to do today really is talk about some of the e-health research that we're doing here in the University of Plymouth, and I'm going to do most of the talking, and then Magid's going to come in. I keep putting it to Magid. I keep getting the wrong camera. Sorry, Magid. Sorry, everybody else. Let's try again. So that's it. We're going between me and the camera and the computer. So talking about our e-health research, and what we're aiming to do really is describe some of the past research, some of the current research, and hopefully identify areas for research collaboration. It would be good to get collaborative research projects with Brazil, with Porto Alegre, and or maybe you got some ideas as well, Bob. And also looking at possible postgraduate study, and to get your views perhaps on the priorities of some of the things that we're doing here. Oh, and Thijs is also there. So hi Thijs, nice for you to be there. Hope you got more than just the 2 of you. Obviously I can't see you, so let me know in the chat room how many people are there, and if maybe other people are logging in. It would be good to know who's there. Just a quick advert before we carry on. The university is currently offering 40 PhD studentships, and these are mainly for home or EU studentships, but if anybody from outside of the EU wants to take them, you can do them and pay the extra difference in the fees. The closing date on those is 26th of May. So if you know interested, probably get in touch with me or Magid or Sita Maramba, who's there in the chat room, to discuss possible projects. But the web address is there, Research Studentships, for the actual details of how to apply. Do feel free to comment as we go through. Obviously, while I'm looking at the camera, I can't be looking at the chat room, but we will stop and have a look at it at the end, and Magid, who's just here, will actually be able to answer stuff as we go through, and Sito will as well. So don't chatter too much though, pay attention to what I'm saying, alright? We could use breakout rooms, but actually seeing as there's so few of us, I think we won't bother, so I'm going to skip through this next bit about breakout rooms. We do use breakout rooms quite a lot when we do this with a bigger number of students. And I'll just sort of tell you that we normally split people up into the attic and the kitchen and the cellar. They type it, they go there, and it means that if you've got a large group, you can divide the group up so there's more interactivity. But we won't bother today because so we'll skip through all that because as there's only so few of us, we can make all the comments in just that one chat room. A little bit of my own history, really. I first started working in the health service, well, more or less my first job anyway, was working on something called the Nottingham Diabetes Clinical System. I had a couple before that, but this was my main first job, and in that job and in that project, we developed a medical summary on paper which we gave to the patient. Gave it to over 10,000 patients, and the system ran for 20 years before it reached 1999 and had to die. But this is where I got interested in giving patients information. So back in the early 80s, we were looking at studies of censoring of the record and understanding of terminology. And really, ever since then, I've been trying to keep that line of research going in terms of what patients do. And it became clear, really, that we should look to see how we could link the health information to the medical record. So in the 1980s and early 90s, we had studies looking at a lay dictionary in hypertension. Some of you may know about the Reed code, which is now sort of joining up with SNOMED and so on. But at that time, we were trying to develop a lay version of it for, at least for hypertension, and looking to see how patients might use touchscreen access to medical records in general practice. I also took a bit of a step sideways and looked at using touchscreen kiosks. Down the left-hand side of that video window, you've got people using a touchscreen kiosk in a pub in about 1991, I think. And that's me with a tie when I didn't have glasses and didn't have so much grey hair. So during the 90s, we were looking at the kiosks for using, giving patient information. And then later on, starting to look at various randomized controlled trials, including this one here, which was to do with computerized cognitive behavioral therapy, where we cited computer booths in public libraries. So we also looked at giving patients with schizophrenia access to their record. So it's a particularly difficult to reach group, and did a randomized controlled trial there comparing access to this tailored information on computer versus community psychiatric nurse sessions. One of the main bits of work that I've done has been in cancer, which is that was done first in 1996 we started it, and then carried it on into 1999 and even right up to 2006. And one of the studies was where we took the medical record and used it as like the front end to general information about cancer. So we took information from a charity that provided information about cancer called Cancer Backup, and then used the medical record to as the front end. So we Donald Smith, for example, I'm not sure if you can read that. No, you probably can't. But what you can see on the screen there is some words with yellow words. It says prostate cancer is described in medical words as being grades 2 to 3, localized adenocarcinoma, and Donald Smith would be able to touch those words and go off into more general information about cancer. And what we did in this study was to compare tailoring the information with more general information for patients with cancer, and then follow that up in 2006. Let me tell you why we followed it up. Because in 1999 we found that people who had access to their own medical record actually showed an improvement in anxiety compared to those who had general information, which was a surprise for us. And so we thought, well, what's the mechanism for that? And it seemed that maybe it was because patients were more likely to share. We knew that they were more likely to share it with somebody at home, and by sharing it with somebody at home, they could perhaps get more social support. By getting social support, it might lead to reduction in anxiety. So in a follow-up study, we looked at that specifically, and that was published in BMJ in 2006. The effects of different forms of information produced for cancer on the use of information, social support, and anxiety. Actually, the second time round, we didn't get the same drop in anxiety that we got the first time, but we did still saw that people who'd given personalised information were more likely to show it to somebody at home. So that's a fairly robust finding. Another study, just going to briefly mention, is one that we did in 2000, which is something that we're following up now in various ways. In 2000, we did a study, or published a study, which was looking at what we might call patient-led learning, both in the way that of what we have to teach clinicians to help patients understand information, and how clinicians need to take into account that patients are now looking at stuff on the web, and there's a three-way relationship there. There's the patient, there's what they do outside the web, and the clinician. But also, of course, that patients actually can help clinicians learn. So we might think of in the future, and this is one of the things we're looking at now, is how patients and clinicians might learn in the same environment. So what are some of the general aims of my research? And my research sort of overlaps a large degree with Maged's, but he's going to tell you a bit more about his in a while, and with CETO's. But these are my general aims, certainly, which is to put the patient at the centre of the collection, storage and use of health information, and to develop what you might call a patient workstation, or what we used to call a patient workstation, combining computer patient interviewing, the medical record, advice and information tailored to their needs, appropriate access to peer support. I say we used to call patient workstation because I think that these days, when you consider the way the information might be stored on your mobile, on laptops, Maged's just been showing me all sorts of interesting things about the cloud computing and the virtual environment. I'm sure we can arrive at a better word than workstation. So maybe you can put your suggestions, please, in the chat room. Back in 1994, that was what we were calling it, a patient workstation. But if you've got a better idea of this idea of the patients working with a whole variety of different things to control their patient information and their patient information giving and their peer support, what would you call it? Can you think of a good word for it? Put your answers now on a postcard. Oh, sorry, no, a chat room, please. General aim number 2, or the general second lot of general aims, is to create a learning environment where patients learn from health professionals, patients learn from patients, and health professionals learn from patients. I think up until now, and I'm sure Bob will support me in this, we haven't used that's the wrong word, we haven't worked with patients enough. We've got a huge army of people out there who can help look at the evidence, help review the evidence, help professionals in their education as well as finding information for themselves. But obviously also important, there's the issue about equity of access, and we need to also respect, I think, individual differences in the way that different people might like to get their information. Just turning around, I see that we've got somebody else, J.H.A. Milton. So J.H.A. Milton, please do tell us where you're from. We've got Ricardo and Thais from Porto Alegre in Brazil. We've got Bob Pike from North America, and we've got a few people from here in Plymouth. So do tell us where you're from as well. So just picking up the last of those bullet points, we want to ensure that there's equity of access and that we respect individual differences. One of the things that always annoys me when I go to conferences is that you always get some speaker who will say more than 100% of the UK population have mobile phones, and I went to a conference in London in 2008 where they had exactly that. Now, apart from the fact that being a mathematician and being a bit pernickety, I would say, well, you can't actually have more than 100% of the population. It's not right. It's also not right because, of course, what it means is there are more mobile phones than there are people, but that doesn't really take into account that people over 75 and even some people over 65 may not have mobile phones. You won't be able to see that graph very easily. Let me give you some of the figures from it. But ownership of technology does decrease with age. So people over 75, only 42% in 2007 have a mobile phone. So we need to think about that group and the over 65s, and even us people who are over 55. I do have a mobile phone, not a very good one, but I do have a mobile phone. Because one of the obvious mistake that the presenter at that conference was making is just to say, well, we count up the number of mobile phones, there are more than the population. Well, that doesn't count. You need to think about denominators. I'd be interested to know, Thais and Ricardo, what the mobile phone ownership is in Brazil. I know that in many countries in Africa, for example, the mobile phone will be the saviour in a way, the main mechanism for health information, because it's much better than any cabled forms of communication. If you want to follow that up about access, there's a recorded webinar on the website that you've just come through called Ehealth. Does it really reach the parts others don't reach? So it's available from our webcast archive, as are a number of other webcasts. Also, one of the things I've been doing in terms of the kiosks is to think about whether kiosks help in improving access. And again, there's another webinar that you'll find there called "Do Health Kiosks Have a Role in 2008?" So you can see some of the other bits of research in more detail. So moving on to some of the particular funded projects that we've got just at the moment. I'll tell you very briefly, one of the projects that we've got is led by Catherine Hennessy, who's from Georgia. Bob, you'll be pleased to hear. And Catherine is a gerontologist, and she's leading this project funded by something called the New Dynamics of Aging, and it's called A Grey and Pleasant Land, an interdisciplinary exploration of the connectivity of older people in rural civic society. So this is a interdisciplinary study, which one work package, which is called work package number 6, which is myself and Sito, is looking at the use of webcasting methods such as we're using at the moment, video conferencing, wikis, to try and connect older people and professionals between centres in southwest England, Wales and the USA. So this isn't exactly health, it's much more social than that, but nevertheless it's looking at the whole issue to do with access and accessibility and supporting people using technology. It's also looking at how technology might affect the willingness of people to share ideas, in this case sharing ideas about older people in rural communities. Next, move on to a chapter that we've just published. That's me, Maged and Sito and others, which is called Patient Preferences for Online Person-to-Person Support. This is about things to do with, like, for example, anonymity. If some people want peer-to-peer support, they want to be anonymous, they don't want to be known. Other people might like to be known. In the type of connection we've got at the moment, you see me, I can't see you. Maybe some people would prefer not to be seen at all, or maybe they would like it where both sides can be seen. Maybe some people prefer it where they can speak rather than type. You're having to type and listen to me. So there's a whole variety of different interfaces, and these may vary according to individual preferences, as well as which may also vary by condition, age, gender, and we have a proposal in at the moment which we're hoping that will get funded to try and explore these in more detail, to try and find out what some of these individual differences are. Moving on to, I mentioned this study where we looked at the idea of patient-led learning. That's sort of come up to date a bit more in a study that we have, which is led by my colleague Christabel Owens in what's called Devon Partnership Trust, which is a nearby part of the NHS. And this study is called Collaborative Learning on the Web, the Role of Online Communities in Public and Professional Health Education, an exploration based on self-harm. Pretty long title. Basically what it's about is about people who self-harm and health professionals being in the same discussion space and seeing what happens when we put both self-harmers and professionals in the same space, same discussion forum. How do they get on? What sort of information do they exchange? Do they disclose whether they're a professional or a self-harmer? And this is funded by a package, or by a program called Research for Innovation, Speculation and Creativity, and it was one of 7 projects for the first time round. Just had a quick look at the chat room there and see Patient Health Station as a suggestion. That's a good idea. Yeah, I like that. I'll steal it. All right. I hope you can got a copyright on it. The idea behind this particular project on self-harm is that is a paradigm shift. As you know, when people first started trying to put across the message about smoking, for example, they said, well, let's give information that smoking harms health. And then people realised that actually it's not enough just to give information. You have to try and engage people, engage communities, and so the health promotion experts, health promotion workers went out and tried to engage with communities, tried to find ways of actually getting them to change their habits. Well, this project that we're doing in self-harm is looking at that paradigm shift online as well. So rather than just providing good quality information and kite marked information as you might do, we want to try and engage. So we want the professionals actually to talk to their communities. So we're looking at the sharing of information between patients or users and professionals. This is just the website that we're developing, and we'll be recruiting people to this study fairly soon, and we'll be getting our first results by about November, I guess. Just going back briefly to general aims. Just seeing how we're doing on time. Okay. On the general aims, another one is, so I've been talking really about equity of access and respecting individual differences and the learning environment. Let's move now back to the general aims, the first set, which was putting the patient at the centre of the collection, storage and use of health information, the patient workstation, or as Tice and Ricardo have suggested, the patient health station. I hope you're still with us. Tice and Ricardo. I see in the chat room there that you're having difficulties. If you do have any problems, anybody else, you can always try pressing F5. It reminds you that above the window here, and restoring the window if you seem to be things seem to be freezing. Moving on to general aims with a computer patient interviewing. We've currently got some proposals looking at computer patient interviewing. Computer patient interviewing has been around for an awful long time. SLAC published what was reckoned to be the first paper in this, the first study in 1966, and so here's our patient on the right here with his tablet computer, passing it back up to his professional, and it's been around an awful long time. So why hasn't it worked? If there's been hundreds of studies since 1966, since SLAC published that one, why hasn't it worked? Well, maybe it has actually worked. It is starting to be increasingly used in the USA, and again, if you look at our recorded webinars, you'll see one from Alan Wenner, who's from Instant Medical History, describing how IMH, Instant Medical History, is used in the States. But it's still not really used here in Britain. I don't know about in Brazil. I don't know if there's any use of computer patient interviewing there. But clearly one of the things is, how does it fit in with working practice? So we've got a proposal pending to try and pilot IMH in the Southwest and carry out a stakeholder consultation in general practice to see if we can get this technology accepted and used here, or at least to find out what the barriers to its use are, and maybe if it can't be used, why it can't be used. I think it can be used. So if Bob, if you've got any experience of using IMH or computer patient interviewing, perhaps you can drop us a note there in the chat room. Similarly, in Tice and Ricardo and others, if you have any experience with this, let us know what that experience is. One of the other things we've already talked about this to some degree, which is using the medical record to help tailor information. And one of the benefits of this is it helps make the information easier to find for the patient. It makes the needle in the haystack, I don't know if you have that expression in your country, but making the needle in the haystack easier to find. So been these series of publications on patient online access to their record, and currently recently been following this up with just a master's project. A nurse from the renal unit in our local hospital has been looking at patient web access to their own records, carrying out what you might call the first stage of the MRC complex interventions, looking at the sort of feasibility of giving patients online to their record and finding out which patients are using it and which ones aren't, to go forward into some sort of randomized controlled trial to try and estimate the benefits. We also have a proposal pending with colleagues in a hospital in Somerset, for those you local, it's in Taunton, looking at the use of a tablet computer to support the consultation in gynecological cancer, where we're aiming to combine the patient interview with recording of the interview. Many of you will know that there's good evidence about giving patients an audio recording of their consultation helps them to remind them what it's about, and helps them to go back and listen to it again, and to think about the consultation with improved outcomes for the patient, and also use the information to tailor it, use the interview to try and tailor more general information to the patient. So that's that's there highlighted in our general aim number 1. I'm just having sort of quick looking at the chat room. I'll come on to the questions in a minute. I can see there's a number of comments and questions coming up. It's great, thanks, and I'll come to them in a minute. Just briefly mention one more thing, which is in this, to do with this interaction and the idea of the patient workstation. There's a lot of sites now on the web you'll be aware of that might use cognitive behavioural therapy to help patients. This is one here called Living Life to the Full. It's been designed by Chris Williams from the University of Glasgow, and Sito and I worked with him. This is the website, Living Life to the Full, and Sito and I worked with Chris and others doing a pilot study of using a chat room for motivational support for WebCT, and we currently have a proposal to find ways of recruiting to WebCT. So one of the other sort of important issues here is, how do you actually get people online in the first place? We talked about access. Not everyone has access, but even those people who do have access to the internet may not think of looking for these sites, or may not know which sites to go to, and we need to think about using some of the other media such as TV, radio, maybe email, and so on. Which is the most effective? Maybe it's most effective just to get the GP to send them a letter. We don't yet know how to get people to the right place online cost effectively. And now to MAGED. So if I press the right buttons, we'll go to MAGED, and no, I pressed the wrong button. That's number 2. No, I'll get it right in a minute. Sorry.
Number 1.
There we are, number 1.
Can we have the presentation?
Yeah, and they have the mouse.
That's it.
So, do you want me to do the gear stick, or are you going to do the gear stick?
Yeah, I'll be using just the PowerPoint.
Okay, so that's what it looks like.
Yes.
The case.
Hello everybody. I'm just presenting for 5 minutes, just a brief overview or a few highlights of what I'm doing. This is an orientation slide just to show my playground, where my research generally fits into the wider spectrum of biomedical health informatics, which spans things like bioinformatics, working at molecular cellular levels, up to public health informatics, dealing with whole populations and even global levels. In this mini sampler, I'm just presenting the concepts, the underpinning concepts of some of the projects I'm involved in. I chose 3 projects for this webinar. The first is to do with dermatology. It's dermatology informatics, so it's a clinical informatics example belonging to the middle part of the previous spectrum I just showed you. It's map of dermatology. Then one to do with older people, geriatric informatics, e-calyx. Again, it's a kind of clinical informatics. Then moving towards the macro scale end of the spectrum to deal with populations and regional and global levels. I have an example about emergency and disaster management in real time. The first is map of dermatology, which is a clinical sort of online resource targeting or aimed at non-specialist clinicians. It's free, anyone can use it. The URL is above. You can just try it, type it into your web browser and go and see for yourselves. It enables users to search for images of skin conditions by body region, and by morphology rather than by condition name. So you decide or determine whether it is something on the trunk, in the hand, also the morphology, is it macular, papillar, etc. And it will give you a clever list of differential diagnoses and the corresponding images. So it's much more useful and natural in answering questions about unknown clinical presentations and diagnoses, especially for non-specialist clinicians. General practitioners, dermatology nurses are specialists, but there are also the generalist nurses. So it's this sort of clinicians. The idea is that these people usually know about the presentations, what they have in front of them. They know about the body region. They can see all of these with the patient, but they don't know the name. It's actually that's the problem they want to answer. It can be thought as a clever dermatology-specific add-on or special interface to Google, intended to answer questions that might otherwise be hard to answer by the average user using the basic Google image search interface. There are a couple of papers arising out of this project. One of them involves a formative evaluation of the project, and the link is at the bottom.
Ricardo's asking if you can speak a bit slower, because we struggle with the
language.
Yeah.
That's the interface. If you are going to visit the URL I've just showed on the previous slide, that's what you are going to see, and I suggest that you go and play with it and get familiar with it, and then you'll be able to judge whether it is useful or not. It has been recommended as a useful educational resource in the latest issue of Dermatology Clinics, Volume 27, Issue 2 of April 2009. The second project is Ehealth, and it's an acronym that stands for Enhanced Complete Ambient Assisted Living Experiment. The objectives are health monitoring of older and elderly persons with multiple chronic conditions, things like diabetes, hypertension, multiple conditions at the same time, or comorbidity, at home and on the move. We do the monitoring 24/7. The other objective is to improve the quality of life of elderly people by increasing their freedom and safety. The third objective, to prevent deterioration of the patient condition by providing continuous support, guidance, and health education. And it's not just the clinicians and the observations and the monitoring, but also feeding back to the patient in the form of health guidance, lifestyle management tips, educational tips that are tailored to their specific individual circumstances. And to do so, all of the above, by providing a solution that is commercially viable, that is reliable, that is long-term, that is acceptable by all users and stakeholders, not just patients, but also organizations, clinicians, and that is maintenance-free in non-technical environments. So it is thus suitable for real-world deployment. So it's not just fancy sort of exotic research, but real-world sort of service that can function reliably for long-term. This is one of the system diagrams, one of the top-level diagrams of the system. I would just like to highlight two of the features in this system. One of them is about smart garments, and these are like ordinary garments that the person wears, but these garments have embedded in their textile or tissue the sensors that together constitute the body area network that would monitor the different vital signs, do an ECG, and all these measurements and observations, do them very seamlessly and transparently while the patient is just wearing a garment, an ordinary garment that looks and feels exactly like an ordinary garment. Another component that is kind of novel or worth mentioning in this system is the tricoder, something a la Star Trek movie, if you have watched the movie. And this tricoder is the home sort of device that the person communicates with, and it handles the vital sign monitoring and measurements and the communication of these data to the remote clinicians. The project is funded by the European Commission through the Ambient Assisted Living Joint Program. It has got a budget of 4 million euros distributed among the project partners. It will run from June 2009 to May 2012, And the partners include 3 universities. One of them is the University of Plymouth, and other small and large industrial partners spanning multiple countries in Europe. The final project is about public health informatics. The other end of the spectrum is dealing or targeting whole populations, regions, countries, global levels. So it's of use by organizations like the World Health Organization and the United Nations organizations, which deal with all sorts of things at global levels. It's based on 4D or 4-dimensional GIS. This is 3-dimensional geographic information system with the added temporal or real-time dimension, so it's 4-dimension. And it serves very well the classic person, place, time triad we all know in medicine and public health. GIS would provide or care for the person and their relation to place. Place is very well represented in GIS as the foundation, and time as well, how these interactions change through time. The idea is to have a collaborative and interactive platform that marries virtual globes like Google Earth and 3D virtual worlds like Second Life, and complement and tightly integrate those technologies with other key web technologies like RSS feeds and data feeds from physical sensors in the environment, in the physical environment, like geo mashups, bringing data from multiple sources and repackaging them to form a new service using tools like Yahoo Pipes. So these are all tools available to us, and using them we are building various concepts or ideas for this future platform. This slide just shows some of the early experiments and early outputs we have produced. We have on this slide some of the technical diagrams of various components of the system and some of the snapshots of the implementation in Second Life, bringing Google Earth and some GIS functionality and multiple layers and themes, sorts of things you find in GIS, bringing them to a virtual world, a collaborative 3-dimensional platform. The bottom end here, the lower right quadrant of the screen, is a screenshot from Yahoo Pipes, which enables you to bring all these sorts of distributed diverse data sources and bring them together in one compound service. These are some of the personal photos of some of my collaborators on this. Some of them are here in the UK in a company called Dayton Limited. Others are at Wuhan University in China, at Yale University, Matthew Scotch in the United States. The idea is that this kind of platforms is much suited for emergency and disaster management in real time, kind of sort of imagine managing an influenza pandemic, God forbid, and coordinating all the actions at global, regional and local level. It's a challenging situation, and you really need a platform that weaves data and services in real time from different sources into a new rich datascape that better reflects the current situation and updates it in real time in many novel ways that also are easier to understand and manage. You don't want to overload or overwhelm your users. The platform should also be secure, enabling multiple distributed persons to see each other, to visualize and manipulate relevant data together in unique ways, to conduct and manipulate 3D simulation scenarios, and to collaborate in real time, each according to their assigned role and access privileges. Finally, we have many early publications arising from this research, and also we thought about a wider application potential of the same concepts and platform, and Ray and I submitted 2 related FP7 proposals just about using these concepts and this prototype platform in different areas to do with information governance and policy making at governmental levels, especially for healthcare policies, and another for digital libraries and e-learning and health education. Well, that's all about the 3 projects in brief, and thank you for listening. Back to you, Ray.
Okay, so let's see if I can get the right buttons here. There we are.
Yeah.
it's very difficult to slow him down. You know, he's like a steam train. Thanks for I've got some questions, so let's pick up some of the questions are really sort of coming through on the first bit still. So while I'm answering some of those questions, you may be thinking of other questions or things that you want Maged to answer, and he can come back into the video window again in a minute. I've got a bit more presentation, but let's sort of have a little breather for a minute and pick up some of the questions there. So Tice, you said that you had a student from the School of Dentistry there. So hello, students from the School of Dentistry. First of all, we have to apologise that we don't speak Portuguese, either of us. Maged, of course, speaks Arabic and French and English, and I can get by on Spanish, but I'm afraid we don't have Portuguese as one of our languages. But you say, Tice, you say that she would like to know if in the patient workstation treatments are suggested or explained to the patient. This patient workstation, or whatever it was you suggested, the health station, I mean, it really is sort of an idea that we're working towards. We have explained some things in the past, so but mainly using explanations which have already been tried and tested and validated by others. So, for example, thinking about the cancer studies, what we've done there is we've taken booklets that have been produced by an information provider in cancer, and then we say, well, this bit actually is, and that bit are the bits which are relevant to this particular patient. So we've tried to really tailor the information, pick out the right bits for each individual. So we're trying to explain treatments, trying to explain diagnoses, trying to explain the conditions, and maybe living with the condition. We're also, of course, wanting to learn from patients about living with a condition, because many professionals, I think, can learn from patients. There are, of course, other systems which in the past have also tried to at least predict to some degree the diagnosis. So when I was in Glasgow, my colleague Robin Neil-Jones worked on a system for abdominal pain, where by use of a whole series of a patient interview, use the information from the patient interview to use Bayesian methods to say, well, the probability is that this is likely to be this particular diagnosis. So those things can be built in, and of course Maged, I know, worked on the map of medicine and things like that. So those things all can come into this idea of the patient workstation. I think really what I was trying to say is there that the focus is that not only do dentists and doctors and nurses deserve a workstation, we think patients do as well, and maybe it's actually better in some ways to focus more on the patient, because if we can help them understand their treatments, understand their different lifestyles, we can perhaps reduce more morbidity than you actually can by concentrating on doctors. I'm just picking up some of the other questions before I carry on. Tice, you're asking, or Ricardo's asking, how can he join the eHealth module? I'll come to that in a minute. I've got another advert coming up. Got the advert about the PhD students, which I might come back to, and someone's asking about the cost for the patient. We're, of course, in the NHS in Britain is essentially free at the point of contact. There are some bits of the health service which aren't free. Dentistry, in fact, is one of the bits that people get charged for quite a lot. But on the whole, it's free, and most of the services that are provided in terms of information are provided free for patients. So if patients were to get access to their own record, mostly it's done free. I guess that might be different in the States, or I'm not sure again about the health service that you have in Porto Alegre. Perhaps you can tell us, is it an insurance system? I'm not sure. Anyway, I'll let you type more stuff in there. If you've got any questions for Maged, again, type away. In the meantime, oh, whoops, wrong. I'm going to carry on with the last bit of my presentation, which was this one here. So just wanted to talk about the learning environment, and just to talk a bit about the webcasting system that we're actually using just at the moment. So we've been using this webcasting for open webcast seminars, much as we're doing today. We've been using it for postgraduate modules, undergraduate teaching, for CPD, which is continuing professional development, and short courses, and for the marketing of courses as well. And for our students, I mean, the distances here are almost certainly far less than the distances that you may have in southern Brazil or in the States. But relatively speaking, in the UK, the southwest, our students are fairly widely distributed, so there are benefits in terms of travel. Students also say it's more interactive than normal lectures. One of the things that you can do at the moment is you can all type at the same time as I'm speaking, rather than stopping and waiting to put up your hand and talk. And many of our students feel less inhibition to contribute in this sort of interaction, particularly when we start using breakout groups. Here's a comment from one midwifery student. I really enjoy the interaction you get from webcasting, much better than a lecture setting, productive use of my time. Another one said, there's more feedback from group members who ordinarily wouldn't say anything during the lecture through dislike of public speaking. So it'd be interesting to know what the students there in Brazil think of this, because I'm sure that you're already used to using video conferencing quite a lot. I'd be quite interested to get your views about this sort of method, assuming that you were there at the keyboard, being able to type at the moment. Other benefits are that it helps save travel. So you know, we're concerned with global warming. We're trying to stop people from travelling in their cars. One seminar for 34 students saved 3,672 miles, which is what, 5,000 kilometres or something like that. And certainly within the NHS it could save quite a lot of money, and it of course enables us to have international collaboration as we're doing today. So Ricardo, you wanted to know about the eHealth module. The eHealth module will run from September the 30th, Wednesday afternoons, 10 Wednesday afternoons, 2 to 4:30 British time. I guess that might be sort of early-ish in the morning for you, Brazil time. Last time round we had students from Malaysia through to the middle of Canada, so Asmawi, who was our student in Kuala Lumpur, was doing it at 9 o'clock at night, while Rashid, who was in Edmonton, was doing it at 7 o'clock in the morning. It seemed to work okay. We've got registrations open now, and we've got 2 scholarships on offer, which is a fee waiver. It's not, you don't get real money, you just don't pay any fees for non-EU students. So if you're interested in that, please contact me. If you're interested just to apply as a possible student, again, just contact me, so email me. If you look on the bottom down there on the screen, it says contact RayJones, so you've got my email there. You can email me. And another project that we're using this sort of learning environment for is to try and get a consortium of hospitals and health authorities in southwest of England to use this method for webcasting and similar for continuing professional development and patient education. I don't know what it's like either where you are in the States, Bob, or where you are, Thijs and Ricardo and colleagues there in Porto Alegre, but on the whole, the hospital computing departments and the health authority computing departments are much more concerned about medical records database applications. They're not really concerned about the learning environment. So we're trying to get a partnership with local health authorities and hospitals to try and make use of technologies like this. And that's really it. We've got sort of 5 or 10 minutes, or as long as you like, really. I'm prepared to stay here as long as you like in the chat room for comments and questions. It says perhaps more in telehealth line is perhaps more similar, but let's hear your views. Any questions for Maged? Just remind you that he is still there, and I'm still here, and I'm going to look at the chat room now to see what you're saying. You're fine there. You're in. We'll leave the microphone on, by the way, so we can just sort of talk to you at the same time. So even though I'm looking over here, we're still here and looking at the chat room at the same time. We haven't heard from. I'm not sure if Jay Hamilton and Anne Charles have said who they are. It'd be good to know who you are. Are you from Plymouth area, or are you from somewhere completely different? Okay, Ricardo, you asked about the what's the module about. If you actually go to, let me see if I can find it. What's the web address? Cito, you're there in the chat room. Can you give Ricardo the web address for the module? I think it's or somebody else. Let's see if I can find it while we're looking. I'm just looking on the. Oops, no, wrong one. Just see if I can get connected on this computer that we're using for the webcast. See if I can find the. It's being very slow. I'll find it. Ricardo, I'll send you the link. But basically, the module is mainly patient focused. It's about patient access to records, health education, patient information. It's about the use of e-learning for patients, doctors. We've got 2 sessions on telehealth that Maged does. So we've got what are we doing this year?
Yes,
we're doing
one on telehealth in general,
yeah,
especially for independent living for older people, and another one for people with dementia.
And then we'll have a session which is normally student led. So that we'll get you to do presentations, so that we learn. Because one of the interesting things that we found last year was we're having students from Malaysia, Saudi Arabia, Mauritius, the UK, West Indies, Canada. It was very interesting learning about their different backgrounds of the students as well. So we had one session particularly about that, and the evaluation of e-health initiatives. That's really it. I can send you the web link to that to have a further look at it. How are we doing on the?
They sent it already.
All right,
Cito's
done it already. Great, thanks, Cito. So, got any other points? If you got some spare time, Bob, it would be good. Yes, have. Unfortunately, the cost of the eHealth module is £300 for non-EU, non-UK students, unless you're the lucky 2 people that get our scholarship. We're offering that obviously across the world, mainly, I have to say, mainly sort of aiming it at African countries or those who can't afford to come. So, certainly, please do apply if you can. Okay, Thijs, I mean, you say that you're concentrating your efforts on e-health activities in projects that deal with poor remote people. I mean, I think there are some links there. Don't think that we wouldn't describe the population of the southwest of England as being particularly poor or remote, at least by the standards of your remoteness. But nevertheless, many older people in the rural communities of the southwest are can be fairly isolated. The geography might not suggest that, but it is the case that there are I think comparisons there, and so looking at the sort of work that I mentioned before, which was let's just go with Catherine Hennessy, where we're looking at older people in rural areas, and of course Maged's work looking at new technologies that older people might help support older people. I think it's quite important. We've certainly got a very older aging population here in the southwest, where our population is probably older than the rest of the UK, and they can be remote. So there are some parallels.
And to answer Ricardo, that's one of the major differences between Western populations, especially in Europe and also in Japan and Africa, because is the difference here. We have a high elderly dependency ratio, lots of older people, while in Africa they have lots of children. It's the reverse. They have high youth dependency ratio. So telehealth there would serve different issues and problems, and would require different technologies as well.
And Tice or Ricardo mentioned about East Anglia being older as well. That's right. Yes, East Anglia and Southwest are the two older areas. I mean, maybe just say a word about. I mean, where are we? Number 2. Clearly, the method that we've developed here for webcasting is a sort of a hybrid method. We didn't go into it too much, but if I zoom actually, I'll zoom the camera out maybe a bit. Wrong one. And no, wrong way. I'm going to go to number 1 and play around here. We've got so we're sitting here with a mixer, but you can't see it actually. No, because the computer gets in the way. But so I'll go back up again, back round again. Sorry about this, giving you seasickness here. But we do have down here like a mixer board. So what we're doing is like a hybrid TV solution, if you like, to webcasting. So we take the image from the camera, the image from the computer. The image from the computer is scanned on got a box here to scan it, converts it into analog. It's then mixed because the technology, although it does say digital video switcher, but it's mixing it anyway here. We're then digitizing it and sending it back out. And Cito, who's there in the chat room, has used open source software for the chat room. Clearly there are other solutions such as Illuminate, MS Communicator, Wimber, and others that could be used for this type of event, and we're probably going to be moving over to one of those soon. But we've been using this now for a couple of years, and it's been served our purpose well. And there may be. I mean, I think you had a bit of a problem at one point with the dropouts. So, I mean, there are certain bandwidth issues, certainly within the National Health Service in England. Many of the computers within the hospitals actually have very low bandwidth, worse than most home computers, and therefore getting this into the hospitals is a bit of a problem for us. And sometimes we have to try and schedule it so that it's out of hours, or get them to use what Maged's using at the moment, which is a netbook with a 3G dongle stuck in the side. That gets around the hospital problem. I'm going to look back at the.
You've got a question here.
Yeah. Okay.
Who pays the professionals? That's for you.
Feed the patient workstation with medical help. Well, they. I mean, patient education is part of their role. So therefore, the developing patient information and communicating with the patients is what they're paid to do by the NHS. So the fact that they spend time doing that in maybe in a different way other than the face-to-face is not something new.
It might even save them time.
It might even save them time. Yes. That
In the long run.
yeah. I mean, as Maggie says, it could save them time. The if for example, we have a diabetes specialist nurse, and the diabetes specialist nurse is currently running education groups for young insulin-treated diabetics. If she can do that much more efficiently, for example, by webcasting, as we're doing, by producing information online that can be matched into their medical record, that in the long run will save her money and be more effective, hopefully. Any more questions? We're starting to get boiling in here. This room actually gets very hot with all the machines. I don't know how Maged's sitting there with his coat on. Look, he's obviously likes the hot weather.
Not that much.
Any more questions? Or comments? Sito, you got anything we've missed out that you wanted to talk about? Bob, are you still there? Any questions? What time is it where you are, Bob? I saw it was 4 hours difference to Brazil, was it? Did I see that somewhere? Okay, so the students are leaving. You've got a class now, so bye students. Thank you for being with us. So bye from Maged as well. And if Tice and Ricardo and Bob and anybody else wants to stay on, we're happy to stay here and answer questions. But thank you for coming. Hope you enjoyed it. Hope we didn't speak too quickly for you. So Tice, you're talking about, I'm sure that's Tice typing as Ricardo, talking about sending an agreement. Fine, yes, go ahead and let's have a look at it and see what that means. And thank you Bob Pike for taking part, and thank you Keith Selms and Jay Hamilton and Anne Charles. And I think we'll probably go, shall we? If nobody else has got anything else to say.
Thank you.
Okay. Right. Bye then. Bye.